So the first part of the informed consent process, the first sort of page, I would say, is exactly the same whether it's feminizing or masculinizing treatment. So I'm going to go through this. So no matter what kind of hormones you're going to be prescribing, there are some basic things that we are going to cover first. And you'll see some of this I've literally copied and pasted out of the information leaflet that goes with the consent form from the guidelines. So the first one is that the decision to start hormone therapy rests with the client, not the healthcare provider. So there's you have to emphasize to the patient that they make the decision, they decide when they feel ready, and they have to take also responsibility for what will be happening. You also need to tell them that a lot of the information out there on the internet might be inaccurate and out of date, and it's very important that we're very clear about what they think is going to happen. I quite often find that patients have got some very strange ideas about some of the things they might have read in the internet. Very important is that every client is unique, so they can't compare their journeys with others. And I think it's helpful to explain to patients that they're basically going to go through a puberty. It's a bit like going again through a female or a male puberty. And just as all children going through puberty, when you go into puberty, you can't compare your puberty with your friend's puberty. We have all a genetic predisposition on how we respond to hormones in our body. And you can't actually tell when a 13-year-old starts developing what they're going to look like 3 or 4 years down the line. And that's very important. So the amount of hormones you take is not going to create a certain amount of changes. And breast size is a good example. So higher estrogen levels is not going to give you bigger breasts. All that will happen is you'll end up developing the size of breasts as indicated by your own genetic footprint. And that's very important because sometimes patients have a little sort of idea in their own heads of think. Okay. See, Chris has just asked me to quickly make him co-host again. Apologies. Just give me 2 seconds. There we go. Then you can help me with the chat and things like that. Okay. So, so part one is that what you can explain to the patient is what I explained a bit to them now. They don't need to see a psychologist or a psychotherapist, but we do want to make sure that they've got a good support structure. So very important, family or friend or some sort of people around them. It's not any journey like this, especially in the society that we live in the moment, does need people around you. Also very important that hormone therapy is very similar to prescribing contraception. It does not need to be done by an endocrinologist or some fancy specialist. It's very much in the realm of the GP or the primary care doctor. And then we also have to explain to them that we have all these awesome people in the team, potentially within the Department of Health, that we can refer them to if they need to. Patients often have a question about gender markers. So one of the challenging things is when you do go through transition, and especially if they've already been socially transitioning, is now it gets very confusing because you are presenting your gender identity as female, but now on your ID you still have a male name and a male gender marker. And this can become problematic, for example, when you are registering for exams or when you go through airport security and you've got a beard and there's a female marker on your ID. And these things need to be thought through. There's social implications because of these two not being aligned. In South Africa, we found out the other day, you've legally allowed to change your gender marker since 1965. So being transgender has been around for a very long time. And that act was updated in 2003 and is currently being revised again. So legally in South Africa, you can change your gender marker to just unfortunately you only have 2 options, male or female. But to be able to change your gender marker at the moment, you need to bring 2 letters from 2 different healthcare professionals that just says you've either undergone medical or surgical gender affirmation treatment. And all that means is you confirm that the patient is taking hormones. And there's nice templates also in the guideline that you can give patients. Home Affairs, you can imagine just getting your normal ID through Home Affairs is quite a thing. Trying to change your gender marker is a whole nother adventure. And this process generally takes years. So patients need to start thinking ahead a little bit in terms of their lives the potential challenges with legal documents and have some sort of plan on how they're going to navigate that. And this is where social workers can be quite helpful, just to help them think around all these different implications of having a different gender marker on your ID than how you present. Then important aspects to consider and that we can explain to them. So remember, you're going through puberty, right? So your emotions are going to shift just like teenagers. You might become more moody, more tearful, more angry, or you might even get more shut down. There's going to be impact potentially on relationships with families and others. So you need to start thinking, how is this going to impact my my situation at home, my situation at work, for example. We're going to talk quite a bit about hormones in a moment and how that might affect your sex life. It might affect safety. The world at the moment is not very safe for transgender people, and particularly around where you go. Just going to the bathroom can be quite dangerous. Potential impact on employment if you're trying to change at work. There's definitely grief and loss for some of the changes and who you've been and what that might be like. Some people notice little odd things like taste changes or body odor changes, appetite and sleeping pattern changes, and it's very much this, you're going to go through puberty, and a lot of these things will eventually settle into a new pattern, but the 2, 3, 4 years can be a little bit disorientating. You also need to explain that they will need regular follow-up and checkups while they're on hormone therapy. In the first 6 months, we see them a little bit often and we do bloods. And then eventually we normally would see them then at 6 monthly follow-up, and they would get a 6 monthly script. We're available, and it looks like we can do this in the public sector. We can actually use estradiol and testosterone levels to be able to monitor when they have reached the same levels as a cisgender or a cisgender woman for that particular gender identity. So let's quickly look at masculinizing treatment and what we're telling our patients. And so for masculinizing gender affirming health, so this is somebody who was assigned female at birth and want to be more masculine. We have 2 potential possibilities. There's no oral testosterone available in our setting. Well, apparently there is some preparations overseas, but we have injectables, and there's sort of a 3-weekly injection that used to be in the public sector, but that recently, so testosterone cypionate, which we do prefer, has recently come back into stock in the last year, and this is now the main one available in the public sector, and I think it's the one also mostly used in private. This does mean an injection every 1 to 2 weeks, weekly being best, but it can be given just like you give the diabetic injections as a subcutaneous injection. So remember also our trans men who was assigned female at birth might have periods, and the testosterone quite often suppresses the periods, but in some people it doesn't completely do that, and then you might want to use, there is additional medications we can use to suppress the periods. So testosterone, yeah, is our, so progesterone is usually what we will use to suppress that menstruation, like the mini pill, and progesterone itself doesn't have any feminizing effects. So the cost in private can be anything between about 150 Rand to 300 Rand per month. I'll show you the public sector costs, and we will discuss that when we go through hormone therapy in detail in the second part of this session. So this is the changes that can occur, and the interesting thing is, especially when people talk about regret, and what if people regret their decisions? The frustrating thing for transgender people is that when you stop the treatment, most of the effects are reversible. So the frustrating thing is that the hormones, unfortunately, it's not that you can go through a quick permanent change. You're going to have to keep on taking the hormones for the changes. The only things that are permanent that we really need to know about is the beard. So if you're on testosterone and you stop, you might end up being left with a beard and some of that male scalp balding, male balding that we see. So if we quickly go through this, you might get some acne, and this table is very useful to go through with patients. And you can see it takes about 1 to 6 months before you start noticing all these changes, but you can see it can take a good couple of years where you're going to battle with acne. And yeah, when you stop the testosterone, it all just goes back to where it was. The beard is normally what the trans men quite like to have, so it can take a good 6 to 12 months before that beard's going to start growing, and just like our teenage boys, it might take a good 4 to 5 years before you actually have a full-grown beard. And then depending genetically in your family, if there's male pattern balding in your family, again, it's going to take a few months. And this is very unknown because it's such a genetic thing. And it will happen usually later in life. So if you're quite young, you might just have a little bit of a receding hairline, but it depends on your genetics on whether later in life you will actually go bald. So just testosterone does increase your muscle mass and strength, but only really if you gym. So if you don't gym, you're not going to suddenly turn into a bodybuilder. And again, it takes a few months for that to kick in, and takes a good few years for that change to happen. And again, all of this is reversible, as is that fat distribution, giving more this sort of straight figure. So it takes a few months, about 6 months, for the periods to stop. And again, this is very variable, and this does seem to be quite reversible. So one of the challenges when we saw the PEPFAR program cancelled, and a lot of people have not been able to access their treatment since March, there's been the horror for some of our trans men with their periods starting to come back, and very dysphoric with that. So clitoral hypertrophy, actually the clitoris does become a bit bigger and grows a little bit. Now, again, very individual, and this is one of those things that are not reversible. And you can get a bit of vaginal atrophy, which for most of the trans men is not even something they'll notice. But if they still are having vaginal sex or internal sex, then one can just treat that with a little bit of estrogen cream. And then the important thing here is the deepening of the voice. So that is the other thing that's not reversible. So if you do end up stopping your testosterone, but again, it's going to take time for that voice to actually break and become deeper, and usually just drops sort of, it drops an octave or so. And again, it's going to take a few years for that to fully develop. So it also means that there's quite a bit of time to decide, oh, okay, maybe I'm not into these changes. And then most of these changes will actually be reversible when you stop the treatment. So the other things that you need to, this is under the masculinizing treatment guideline, that you want to tell your patients, is that there's limitations. It cannot reduce your breast size. So the breasts you already have, that's the way it's going to be. They might be slightly easier to flatten them. It cannot make you grow taller. And there are some risks. So we have to tell them about the polycythemia. It means your red blood cell count can increase. It's the most common sort of risk. And all you do is you donate blood. So that's quite easy. As we know, estrogen is quite protective. So our women tends to have lower risks of heart disease than men. So if you go onto testosterone, you will end up having the same cholesterol risks and blood pressure risks as the cisgender men of your same sort of age and constitution. Liver complications, as with all contraception, like we have with contraception as well, but very, very uncommon. And of course, just like puberty, if you do have psychiatric symptoms, it may worsen anxiety or psychosis. And again, not common, a bit similar to contraception. The main side effects is the mood swings, the puberty mood swings, which does eventually settle down. Aggression, not a major problem, but people might feel more on edge. Similar again to our teenage boys. Bit of acne, that's probably the biggest complaint. And that androgenic alopecia is that male pattern balding. Obviously, we don't want to give testosterone to people who are pregnant, so you have to do a pregnancy test, or if they have a sex hormone sensitive cancer or polycythemia. So the most important conversation you actually have to have, because this is the one where you can't go back, and this is especially a conversation when you've got young people. Again, it takes a while to become infertile on this treatment, and it's also not in all patients, so you still have to talk about contraception. But you have to have a long talk about fertility. And it's not so much about talking also about may not be able to have their own genetic offspring and how they feel about this. In private, there's obviously the option to actually preserve your genetic material and to have a conversation around things like adoption if they do want to have children one day but are not able to have their own genetic offspring. And then we're quickly going to go to what we specifically tell our women, our feminizing treatment. So as I've said, there's the first bit that's the same for both. We've just covered the masculinizing treatment, and now we're going to look at our feminizing treatment. So this is for our trans women. And again, we're trying to induce feminization. And by far the best option is injectable estradiol, because it bypasses, you don't end up having estrogen going through the liver. So one of the challenges is that when you take estradiol orally, it gets broken down in the liver. It does still have effects on the body, but to get the same level of effect, you have to give much higher dosages, and then the risks go up. So what we do with the estrofem is to be able to get the same effect, is that you actually give an anti-androgen that suppresses the testosterone at the same time. So if you're taking oral treatment, you're going to be on 2 different treatments, and I'll show you what that looks like. So the cost in private is somewhere between 150 to 600 Rand per month, and that depends a little bit on the preparation that you are using. But actually we get the medicines for much cheaper in the public sector. So again, this is the slide that you spend time on with your patient. This is the one they're all interested in. Remember, these are all the effects they want. And again, the challenge is you stop the treatment and you're going to lose most of these effects. The one you don't lose specifically is breast growth. So that's the thing you're going to be left with if you end up stopping the treatment. So if we again look, your body fat distribution, decreased muscle mass strength, skin softening, it takes a few months to get more of that female skin and body shape. And it takes a few years to come fully into effect, but this is all reversible. I'm going to talk about sex in a minute. And then decreased sperm production. We'll also talk a little bit about fertility just now. And then what's nice with the feminizing hormone therapy is if you are somebody that has a bit of male pattern balding, then that actually quite often the hair thickens out and the hair grows out a little bit. And this effect continues as long as you stay on the treatment. But again, the challenge is most of these are reversible. The challenge for our trans women is that the voice box is a sort of a structural, physical thing, and therefore the estrogen has got no effect on the voice. So the voice stays quite deep. And quite often this becomes one of the biggest challenges for them in terms of being able to pass as a woman, especially on the phone, for example. And so our speech therapist here has quite an important role in actually helping them in how to work with voice and modulation of voice, and being able to actually pitch at a slightly higher tone. So this is also what we need to tell our women. So again, it does not completely eliminate facial hair. So if our trans woman has got a beard, they might still have to shave. Quite a lot of them will go for laser therapy to remove all of that hair. You can wait a while on the hormone therapy to see how much it will thin out, and then see how much you need to do electrolysis or laser therapy or whatever. We've talked about the pitch of voice. It's obviously not going to change your bone structure. And some women find it if they've got a very prominent Adam's apple, they might find that quite difficult. And also the estrogen is not going to remove that. So our risks here is exactly the same risks we worried about when we're putting women on contraception. So there's a risk of deep vein thrombosis. It's a very low, especially if you don't have any other risk factors, it's again a very low risk. But it's obviously just with our contraception, something we have to talk to our ladies about. But the challenge becomes then in the higher age groups, and particularly those that are smoking or those that have pre-existing medical conditions. And these I would refer to endocrinologists to have these kinds of conversations with in terms of the risk of these things versus taking hormone therapy. Gallstones, diseases of gallbladder is a potential, but again, we don't see that very often. And prolactinomas, again, it has been described very uncommon, and we need to be able to give them ideas of what to look out for so that they present early if there's problems. Main thing is actually the side effects, which is again our adolescent side effects. So headaches, mood changes, changes to the sexual response cycle. I'm going to talk about sex in a minute. So that puberty that we're going through again. Some of the contraindications, therefore, is if they've had a DVT before, or if there's some other reason why you're concerned they might get a thrombosis or a clot, if they have an active sex hormone sensitive cancer, or they've got some sort of advanced chronic liver disease. And yeah, I've mentioned those side effects. And then again, fertility is the big conversation. And similarly, especially in that early first 6 months, 1 year, you are not guaranteed to not be infertile. So they must still use contraception, and condoms, for example, is still key here. And if you stop the estrogen early on, especially in the year or two, again, like we've had in the last year, if you're running out of treatment or you're not able to access treatment, then that fertility quite often returns. But we want to be over careful. If you're going to take this treatment for years and years, then in our trans woman, that testis will eventually atrophy. And so again, we want to talk about cryobank to preserve genetic material, much cheaper for sperm than it is for the ovums, for example. So worth a discussion. This is what the 2 informed consent forms look like. So that whole leaflet is a lovely leaflet that I print out, I give to my patients to read and look at in detail. We go through all of this in detail, and then before they start, they're going to sign this form. So just in conclusion, then our best practice consideration is make sure that our client understands the information at their preferred language and literacy level, avoid gatekeeping, avoid moral judgment, respect your client's timing and their goals. Review and reaffirm consent. So always make sure that why are their goals? Are they still happy with what's happening? Sometimes some women go, actually, I'm happy with the changes as they are. And then comprehensive care is very important. So look at your mental health, look at your sexual health side, look at your safe follow-up symptoms, and make sure that you are legally and ethically compliant as aligned with our HPCSA, our Constitution, our Children's Act, POPIA, Batopelo, etc., in terms of the informed consent process. Thank you very much. So that's just on informed consent. Great. And I've said to people, you're welcome to introduce yourself in the chat so we can see who you are. It's lovely to get to know different people.